over 30 people there. So good morning. This is Carlos, and we're doing grand rounds. And today we have one of our own that's gone over there to Switzerland to do some further training. It's Dr. Malebranche, and he actually did his medical education at Bern University. Right now he's doing a year of structural heart disease fellowship. He did his interventional cardiology fellowship here. He's also had some training at Harvard Medical School with the SQIL certification program. Did his cardiology training at the University of Toronto and internal medicine at Memorial University. So he is applying for one of our positions here in interventional cardiology, and he's done some interesting work throughout his brief but very productive career, and he's going to give us a talk on one and done, evaluating patterns of LV assessment in patients with ACS Choosing Wisely, something that is close to my heart, the choosing wisely part. Okay, Danny, go for it.
Thank you. So thank you kindly, Carlos, for the introduction, and thank you to everybody for attending the virtual rounds here. I can certainly imagine that everybody's schedules are quite busy, and I'm grateful that you've taken the time to attend the rounds. And if you are involved in the care of ACS patients, I hope you're able to take something away from this talk. So just a couple of housekeeping things. If the audio cuts out, it might cut out for a few seconds from time to time. Just let me know, maybe with using the hands up function, comment, or just interrupt me, because otherwise I don't know if you guys can still hear me or not. And this is going to be a reasonably interactive talk, so don't hesitate to ask any questions along the way. Okay, so everybody can hear me. Presumably the objectives for today are to basically review the Calgary experience with respect to assessment of LV function in patients with acute coronary syndrome. We're going to position these findings in the context of what's been published so far, and hopefully we'll be able to finish off with a nice discussion on the implications of the findings of this study, and maybe the merits of perhaps a selective strategy with respect to the assessment of LV function in patients with acute coronary syndrome. Before we get started, I'd like to introduce you to three patients. The first one's patient A. He's a 62-year-old gentleman with established cardiovascular risk factors, comes in with typical chest discomfort and alerts the EHS. An anterior STEMI is diagnosed in the field. He's KILUP1, brought emergently to the cath lab, where he's found to have hypokinesis of the anterior wall, but otherwise preserved left ventricular systolic function. As expected, his LAD was occluded at the proximal segment, and this was treated with primary PCI without complication. His convalescent period was unremarkable, and on the second admission day, an echo showed a Simpson's biplane of 57%. So you're getting ready to see patient A in clinical follow-up, and I'm wondering how many people in the virtual world there would want to reassess his left ventricular function as part of his follow-up plan. So I think there is a hands up function here. Maybe just put a few hands up if you want to regarding that, and we'll see. Okay. Just gonna minimize this chat screen there. Okay, the second patient's a 63-year-old female. She has cardiovascular risk factors and diabetes, comes in with more of a GERD type presentation. She's seen in the emergency department. She has some fine crackles at the bases. Electrocardiogram is unremarkable, but the troponin was elevated. So she was managed empirically as an NSTEMI. An echo showed mildly reduced LV systolic function with an EF of 45%. She had no valvular pathology, and in the cath lab, she had 40 to 45% with respect to LV function. She was found to have double vessel disease, and this was amenable to PCI, and she received 2 drug-eluting stents, one to a pretty big RCA and an OM. So you're getting ready to see patient B in follow-up. NSTEMI mildly reduced LV systolic function. Anybody want to reassess her function in follow-up? I wasn't able to see the hands, But if, oh, there's a check mark on the screen. Okay, so we're seeing a few hands go up. The final patient's an 82-year-old gentleman. He's got a little more in terms of cardiovascular baggage, as well as medical disease. He's got COPD, intermittently on home oxygen, and ethanol misuse. He comes in with more of a heart failure presentation, NYHA 3 to 4 with orthopnea PND, and in the emergency department, indeed, he's in clinical heart failure. The troponins were elevated, the stat one was at least, and his electrocardiogram was fairly concerning for dynamic changes. He was taken to the cath lab as a high-risk NSTEMI, where he was found to have profoundly reduced LV systolic function, EF in the range of 25 to 30%, and triple vessel disease. At this point, the procedure stopped. He's taken off the table with the goal of having a multidisciplinary discussion at the heart team rounds. In the interim, an echo shows an EF of 27%, no LV thrombus, and no primary valvular pathology. He started on the right medications, and ultimately a decision is taken for multivessel PCI. Anyone want to reassess his LV function at 40 days or more? There was a little hint there. Okay, so from observational experience, this actually isn't an uncommon phenomenon to see patients have multiple assessments of LV function, maybe 2 at index presentation, and perhaps 1 or more at clinical follow-up. This table here, hopefully you guys can see it, summarizes the 3 patients who I introduced you to. The first one was the anterior STEMI, normal LV function, who was doing great at follow-up, and his repeat assessment revealed an LVEF of over 60%. The second lady with the diabetes and mildly reduced LV function was NYHA 1 to 2 at clinical follow-up, but her EF had improved from about 45% to 55%. Finally, the third gentleman with the heart failure presentation, he still remained symptomatic, NYHA 2 to 3, but his EF had improved to 39%. So what did the guidelines say with respect to assessment of LV function in ACS patients? The STEMI and NSTEMI guidelines are getting pretty old now, getting up on 7 years. The STEMI guidelines recommend that we do a contrast left ventriculogram, or the so-called LV-gram, at the time of urgent cardiac catheterization, and do the echo if you think there's a VSD, free wall rupture, or pat muscle rupture. In patients with significant LV dysfunction, at index presentation, a reassessment of LV function should take place at least 40 days or afterwards, and this is based on the MADIT data. The NSTEMI guidelines also recommend assessment of LV function, but they actually come out and say, you know what, we recommend that you guys do an
We're losing you there, Danny.
echo pathology, however. Pardon me? Oh, yeah. Can you hear me now? Okay.
Yep.
Yeah, sorry. Okay, thank you for letting me know there. I did get a little notification saying that the internet connection was unstable. Are we, can you hear me now, guys?
Yep.
Okay, perfect. So basically, I don't know how much you missed, but the STEMI and NSTEMI recommendations are there. But what's less clear is how many LV assessments should be done, and more importantly, what should be the pattern of LV assessment in patients who are reasonably uncomplicated and have preserved LV systolic function at index presentation. This is actually quite a large group of individuals, over 2/3 of NSTEMI patients and nearly half of STEMI patients. And there was some work from Derek Chu that this number, that suggested this number is even higher, up to 80% of ACS patients. So who cares about a Choosing Wisely initiative in the first place? Well, firstly, there are obvious cost implications that are associated with redundant testing. There's some literature to suggest that LV assessment leads to actionable change in only 1/3 of patients with acute myocardial infarction, and repeat assessments of LV function in this patient population yields additional findings in only 11% of ACS patients. There was an interesting study that was published just last year in JAMA Internal Medicine that evaluated hospitals that perform the highest rates of echo and compared them to hospitals who perform the lowest rates of echo. They found that the hospitals that perform the highest rates were associated with increased costs, slightly longer lengths of stay, but actually no difference in clinical outcomes in comparison to those hospitals who perform fewer echoes. This brings me to the objectives of the ACS Choosing Wisely study. We essentially wanted to audit the practice of LV assessment in ACS patients in Calgary. And as you know, this is a very high volume center. And more specifically, we were interested in the results of frequency and findings associated with LV investigations at index presentation, as well as those that take place once the patient's been discharged from hospital. And we are particularly interested in the deltas of LV function. It's hypothesized that a single assessment of LV function is probably sufficient in the majority of ACS patients in a PCI era. This study was approved by the Conjoint Health Research Ethics Board at the U of C with waiver of individual consent. So we'll go through just very quickly some relevant definitions, how we created our cohort, and how we collected LV function, both at index presentation and clinical follow-up. The definitions are actually fairly straightforward. An index LV assessment indicates that an assessment of LV function has taken place during the index hospitalization. However, when I speak of something in regards to LV value, that means that we know what the result is of a given LV assessment. A follow-up LV assessment is defined as one that takes place once the patient has left the hospital. We looked at ACS patients over a 5-year period. We used the public health care numbers to link the patient data from the following sources, which you can see there. Clinical demographics were provided by the Approach Registry. The in-hospital echocardiogram labs provided important information regarding assessments during the index presentation. We assessed the results of echoes at the major outpatient echo labs in the city of Calgary. And this was supplemented with information regarding LV assessment that could be collected from physician billing claims. And finally, we collected the discharge information from the DAD. So you're probably wondering, how did we classify these patients, or how were the patients stratified? How were ACS patients stratified in this analysis? We binned them into one of 3 categories that you can see there in green, amber, and red, which respectively represent normal LV systolic function, intermediate LV systolic function, and severely reduced LV systolic function. We used the information from the transthoracic echocardiogram, namely the LVEF percent, to bin the patients. If this wasn't available, then we used the EF percent from the contrast left ventriculogram. Now, once we started collecting data, we noticed that not all reports had a given or a specific LVEF percent. It's not uncommon for some reports to indicate a range of EFs, and we used that information because it was still important to us. And there were instances where assessments of LV function were graded using qualitative terms, and this is still very important, and we use that information. So if the study said this is normal LV systolic function, it went into group 1, as you can see there, mild to moderately reduced in 2, and severely reduced in group 3. So we were good to go once we had the data from all sources. The patients were merged. We had our LV function binned according to the 3 groups at index presentation, as well as clinical follow-up. Unless otherwise stated, the data I'll present to you today are mean plus or minus standard deviation. The conventional significance of p-value being less than 0.05 was taken, and this was calculated using a one-way ANOVA, and chi-squared for categorical variables. The statistical analysis was performed with the software shown at the bottom of the slide. Now, we have a quick question. Can anyone guess which country this picture hails from? And you can interrupt.
Switzerland.
Very good. We have somebody who's awake. Excellent. So let's move on to the results. We'll walk through the following consort diagram. Nearly 9,000 patients had a diagnosis of ACS between 2012 and 2016. If there was no available information regarding the baseline level of LV function, or more specifically, the LV function at index presentation, then you were excluded from the analysis. So that's shown here on the right side. Hopefully you can see the mouse. Our study cohort therefore consisted of just over 8,300 patients, 8,327, and you will see this number in subsequent slides. Now we found that 55% of the cohort of ACS patients, or 55% of the study cohort, had additional assessments of LV function once they left hospital. We looked at the results of these LV assessments in a large subset in 3,000 patients, which corresponded to over 5,000 echoes. And sorry, I'm parked right next to a Vespa garage, so you may hear some very small motorcycles speeding off from here. And with respect to follow-up, 2/3 of the patients in our large subset that we investigated the results of the echo, 2/3 had a single follow-up, namely 2,000 patients, and 1/3 of this cohort had more than one follow-up. So what was the flavor of our ACS cohort? Well, I'll tell you right off the bat, 66% of them had preserved LV systolic function, shown here at the top, and this is more or less consistent with some of the data that I presented to you from other reports at the beginning of the talk. Here's our 8,327 here with the mean ages and some of the clinical demographics. We have our color-coded bins of LV systolic function, group 1, 2, and 3 in green, amber, and red respectively. And if you focus your attention to the right side of the figure where we have the patients with severely reduced LV systolic function, they tended to be older, more frequently associated with or had a higher amount of diabetes, and were more frequently associated with a STEMI presentation. Now, if we swing down to the bottom over here, we have the mean LVEFs for each of our 3 groups of LV function at 61% in group 1, 44 and 27% in groups 2 and 3 respectively. Now, if you shift your attention down here, you'll look at the frequency of LV assessment with left ventriculography for the whole cohort, and you'll see that it's quite high at 96% of the cohort of ACS patients who underwent assessment of LV function with left ventriculography. The frequency of transthoracic echocardiography in this patient cohort overall was 51%, but you'll see that the frequency of echoes increases as the LV function worsens. Up to 74% of the patients in group 3, for instance, had assessment of LV function by way of echo. Now let's focus on index presentation, because we've been talking about assessment of LV function with contrast left ventriculography and assessment with transthoracic echocardiography. You're probably wondering what the rates of duplicate assessment are in this patient population. Remember the magic number of 8,327, that's our whole cohort here. Gray represents the proportion of patients who undergo duplicate assessments of LV function at index presentation. And as you can see, overall, just under half of the cohort of ACS patients had duplicate assessments of LV function. Now, if we swing our attention over here, we have our color-coded groups, and you can see, not surprisingly, that the proportion of patients who undergo duplicate assessments of LV function increases as the LV function worsens from 41% in your group 1 patients up to 59% in your group 3 patients. That's what was happening at index presentation. What's happening in ACS patients once they're discharged from hospital? We found that over half of ACS patients undergo additional assessment of LV function. Shown here, again, we have our 8,327, and 55% of them had at least one or more follow-up assessment of LV function once they left hospital. And again, we see an inverse relationship between the frequency of subsequent assessments and with respect to the LV function. So as the LV function, put in other words, worsens, the proportion of patients who undergo additional assessment increases to 68%, for example, in your group 3 patients. Now, you're probably wondering, I'm just going to close the window here, one second. You're probably wondering what happens at the quantitative level with respect to changes in LV function in patients once they leave hospital. So again, we have our color-coded groups here, 1, 2, 3, shown in green, amber, and red respectively. At the top of this table, we have the median LVEF of ACS patients during index presentation and the EF at the first clinical follow-up. And as you can see, there's no significant difference in your group 1 patients. In group 2, we have a median EF of 44% at index presentation, and this significantly increased to 52% at the first clinical follow-up, and we saw a similar trend of significant increase in EF from from index presentation to first follow-up in our group 3 patients. In those patients who undergo multiple assessments of LV function, we compared the results of the LV assessments from their first clinical follow-up and their last clinical follow-up, and that's shown at the bottom of this table here. There were no differences noted between these 2 time points in our group 1 patients. There was a numeric trend towards an increase in LVEF in our intermediate LV function patients, and there was a significant increase of LVEF in our group 3 patients when you compare the first clinical follow-up to the very last clinical follow-up. So that's what's happening at the kind of the numeric level. Let's have a look at what's happening at the categorical level. So here we have our cohort of patients with respect to where they were at index presentation. Group 1, the number of patients who were in group 2, and group 3. And on the right side of this table, we are interested in seeing where they ended up or which bin they ended up at the first clinical follow-up. In those patients who were in group 1 at index presentation, nearly 90% of them remained in this category at the first clinical follow-up, with 10% tumbling down to group 2 at the first clinical follow-up, and only 1.1% dropping down to group 3 at the first clinical follow-up. By comparison, we have our group of patients who started in the intermediate LV function at index presentation. Over half of them bumped up to group 1 at first clinical follow-up. 40% remained in the very same group at the first clinical follow-up, and only 5% decreased to group 3 at the first clinical follow-up. Now, I'd like to draw your attention to a fairly striking finding, and that was with respect to the movement of patients who started in group 3 at index presentation. Nearly a quarter of them bumped up 2 categories to normal left ventricular systolic function at their first clinical follow-up. Over a third improved at least 1 category, as shown here in yellow, and then 40% remained in the very same group at the first clinical follow-up. I won't go through all the movements in this table here, but basically the purpose of this table was to evaluate, was the trend similar when we compared ACS patients with multiple follow-ups, more specifically, the movement between categories at their first clinical follow-up versus their last clinical follow-up. And we found that 85% of ACS patients retained preserved LV systolic function at their last clinical follow-up. For those of you who are more visually geared, like myself, we have an alluvial diagram here, which gives you a visual representation of the movement of ACS patients at the different time points in the patient journey. Here we have LV function at index presentation, LV function at the first clinical follow-up, and LV grouping more specifically at the last clinical follow-up. We have our 3 groups of LV function, which you'll remember are normal, intermediate, and poor, represented by 1, 2, and 3 respectively. And 0 means that there was no follow-up assessment or no data regarding follow-up LV function. So focus your attention on our group 1 patients at index presentation. The majority of this band remained in group 1 at the first clinical follow-up. A relatively smaller proportion ended up in group 2, and then that 1.1% ended up in group 3 at the first clinical follow-up. And then the right side of the alluvial diagram compares the movement between groups between first follow-up and the very last follow-up, and the trend is more or less comparable. Group 1 patients, the majority of them remain in group 1 at the last clinical follow-up, and just a tiny sliver ending up in group 3 at the last clinical follow-up. So at this point, you're probably wondering, what are some of the predictors of subsequent assessments of LV function? We found that if you had bad LV function at index presentation, the odds of having a subsequent assessment of LV function at discharge was higher, and this wasn't too much of a surprise. We found that if you had a STEMI or NSTEMI presentation, you were more likely to have assessment of LV function down the road. And finally, if there was a history of revascularization, such as previous PCI, previous CABG, then you were also more likely to have additional assessment of LV function. This picture reminds me that it's time for our next quiz. True or false? This picture was taken in Ecuador. We're hearing some falses. Okay, another thing you're probably wondering at this point is, what was the timing with respect to subsequent assessment of LV function in the discharged patients? The majority of patients, namely 67%, had subsequent assessment of LV function less than 6 months after they were discharged from hospital. What was interesting, though, is that there was a group of patients, and this is not insignificant, who were being followed after 2 years from discharge from hospital after their ACS event. We also found that patients who had multiple assessments of LV function were more likely to be seen sooner after discharge from hospital, namely 5.5 months, versus those who had only a single follow-up of LV assessment were seen nearly 9 months after discharge. And this reflects probably more of a hands-on practice pattern. So to summarize at this point, we've presented some data from the Calgary experience. We've found that the majority of patients, that 66%, had preserved LV systolic function at index presentation. We found that nearly a half of them, 46%, underwent duplicate assessments of LV function, and this was just at index presentation. More than half, or that 55%, underwent subsequent assessment of LV function, and at least from our detailed analysis on over 5,000 echoes, nearly 90%. Pardon me? Oh, sorry. I thought that was a question there.
I think we got some people that need to mute themselves.
Yes. Don't hesitate to just hit that mute button if you have a chance. And finally, after analyzing over 5,000 echoes, nearly 90% of ACS patients who had preserved LV systolic function at index presentation remained in a category of preserved LV systolic function on the first clinical follow-up, with only 1.5 declining to a level where device-based therapies would be indicated. So just to review a few strengths and a few weaknesses, this list is not exhaustive. We evaluated a fairly sizable cohort at 8,300 patients, and as mentioned in the previous slide, the findings from over 5,000 echoes were harvested. The limitations, well, it's a single center study, retrospective analysis, and of course there are associated selection biases that are relevant. Another limitation could be the merging of multiple sources of data. And more importantly, we didn't collect the indication for echo. So if you think of a patient who has aortic stenosis, and as some of you may know, the risk factors for CAD and risk factors for aortic stenosis they overlap significantly. There may be a patient with multiple echoes, but these are entirely appropriate because they're being followed for progression of aortic valvular disease. Another important limitation is that in this analysis, we looked at LVEF as the sole parameter of LV function. And as you know, there are other indicators of LV function, specifically wall motion abnormalities, strain, diastolic dysfunction, and all three of these have actually been tied to clinical outcomes in ACS patients, and we did not evaluate those parameters in this study. But nevertheless, LVEF is still a very important prognosticator in ACS patients with respect to hard outcomes. And there's some data that I'll show you here that was performed in over 100,000 patients in the United Kingdom, including NSTEMI and STEMI, which are shown respectively on the left and right sides of the screen. And these ACS patients were stratified according to good LV function, which is shown in blue, fair and poor, which are shown in red and green respectively. And as you can see, the unadjusted survival drops substantially out to 7 years in the patients with poor LV systolic function according to LVEF. So what other studies have reported lower value testing in cardiac patients? Well, there was one from Kevin Bainey and colleagues published just last year that found that the rates of NICT, which stands for non-invasive cardiac testing, 1 year after ACS, are continuing to increase it with time, and they appear to be escalating, the costs appear to be escalating out of proportion compared to the incidence or growth of ACS in the province of Alberta. Mike Fralick and colleagues looked at the value of kind of standing echoes in patients who have cerebrovascular accidents, strokes, TIAs, for example. They found that the majority of the studies were normal and very rarely did they lead to changes in management. So I'd like to propose to you the ACS Choosing Wisely approach. If we have an ACS patient who's uncomplicated, quote unquote, by uncomplicated, this is hemodynamically stable, no clinical heart failure, no arrhythmia, etc. At index presentation, a single assessment of LV function should be strongly considered. Furthermore, if that LVEF is within normal limits and there are no other concerns with respect to that patient, then perhaps no subsequent follow-ups of LV function would be required in that patient, if you consider an inferior STEMI, for example. By contrast, if you have more of a complicated patient, then of course the management would depend on the clinical practice guidelines, the clinician's discretion, etc. But again, a single assessment of LV function at index presentation should be strongly considered. If the LV function is moderate or severely reduced, or if the physician is concerned, then of course, after initiating guideline-directed medical therapy, a reassessment should take place to see whether or not additional therapies would need to be employed. So if we apply the ACS Choosing Wisely approach to the 3 patients who I introduced to you earlier, patient A was the 62-year-old anterior STEMI. Despite it being an anterior STEMI, he was revascularized fairly swiftly. He was put on the right medications and he made some changes to his life. And so just consider doing that single assessment of LV function, no further follow-ups. The same applies for patient B. This lady's LV function improved, and therefore repeating assessment of LV function might not result in game-changing management. And finally, patient C, you're obligated actually to reassess the LV function. He was the one who came in with an EF in the range of 25%. But again, a single assessment of LV function should be strongly considered at index presentation, and then reassess it 40 days afterwards to see if he's a candidate for device-based therapy. So here are our learning objectives, which I hope we were able to achieve this morning. And I'd like to leave you with, the following question. I put one and done because I'm sure there will be some, I put one and done question mark, because I'm sure there will be some questions afterwards, and hopefully we can discuss this if there's time. But I'd like to leave you with the following. The majority of ACS patients have preserved function at index presentation. At least the data that I presented to you today indicates that repetitive assessment of LV function doesn't appear to be an unusual thing based on the data. And this is also consistent with some of my observational experiences at other centers too. The data indicate that the repetitive assessments of LV function don't appear to be associated with findings that would mandate at least device-based therapy. Some of the newer medication therapies do play an important role, and this may come up in the question and answers with respect to triple heart failure therapy being required at an LVEF of less than 40%, and we can talk about that. But the bottom line appears to be that a single assessment of LV function may be sufficient in the majority of uncomplicated ACS patients, and this may actually comprise an effective strategy with respect to cost reduction in cardiovascular care. I'd like to acknowledge my collaborators. This project certainly would not have been possible without them. Sarah Hassan and Marinda Fung did all the heavy lifting. Jane Liang provided expertise with respect to the biostatistics, and there are some ongoing analyses with respect to outcomes that are in process. The outpatient assessments of LV function, we would not have been able to obtain this information without the collaboration from Patrick Champagne and Greg Schnell. Stephen Wilton and Brian Haar, thank you very much for providing the research expertise and critical feedback with respect to the preparation of this project. The teams who are responsible for caring for patients with ACS, so the cardiology ward, CCU, and the cath lab, and Todd Anderson for being the captain of this project. Thank you for your attention.
Thanks, Danny. That was great. You go to the chat box if there's a few questions and comments. So one question is, what is the role of CMR in the LV function assessment?
Yes, so very good question. And we did look at, with respect to the billing claims, frequency of CMR in ACS patients, they represented a fairly small group of patients in our cohort, but there are reports that have looked at certain features in CMR, for example, LGE, et cetera, and that's been tied to clinical outcomes, certainly in ACS patients. So we didn't unpack this further, but certainly CMR is a valuable tool with respect to predicting outcomes in ACS patients after their event.
And Steve was asking if you could talk about the role of the LV-gram. There appears to be a lot of variability in their use around the country, and does every ACS patient need an LV-gram?
Yes, so great question, Steve. The variability does exist, and it's fairly substantial from one center to the next. I gave, this talk in another province, and their rates of LV-gram were probably more in the range of 30 or 40%. And there could be a number of factors that may contribute to this practice pattern, whether they're conscious or unconscious. And so indeed, there are variations in practice. And perhaps not all patients would require an LV-gram. I think my bias would be if you have a STEMI patient and they're in the lab before they're anywhere else, then for sure you need the LV-gram. In the LV-gram, as somebody who's trained in invasive cardiology, can be very valuable in trying to understand where the so-called culprit lesion is. So we look for subtle abnormalities with respect to wall motion. You can also see, for example, that late presenting STEMI patient who has mitral regurgitation, and that's a game changer because you're not going to put a stent in that patient if they're a surgical candidate, and a stent could actually
We lost you there.
Introduce a little bit of harm to you and committed a potential surgical candidate. And STEMI patients like, oh, sorry.
Yep, we got you back.
Can you hear me now? Okay, and I am getting a notification the internet connection was unstable. Basically, I'm not sure how much you missed, but in STEMI,
just because
LV-gram
is an unstable test. So that's what's going on.
Okay, so yeah, LV-gram in your STEMI patient population, they're already there. It should be done. If you have a NSTEMI patient who's already had their echo in the CCU or the cardiology ward, then perhaps the added value of an LVgram might arguably be a bit on the lower side.
So other comments here, Dean highlights that there was a recent trial that looked at assessment and follow-up of LV function using different modalities, and that obviously there were significant differences between the different modalities. And how does this affect your study?
Well, so I guess if I understand the question, you know, there you can look at CMR, you can look at you know, more sophisticated parameters with transthoracic echo, for example, strain diastology. With respect to this study, at least during those time periods, transthoracic echo seemed to be the most frequently used assessment of LV function. And we have a long experience with respect to outcomes and LV systolic function going back decades now. And I guess some of, you know, the strain, these are new to prime time. How would this change kind of my approach moving forward? I think I'd, you know, be very cognizant and aware, and I'd like to follow up the literature to see where things go with respect to the alternative modalities. I didn't mention nuclear, but some patients undergo nuclear assessment of LV function. But I think that as far as performing a so-called test of change in clinical practice, as echoes continue to at least appear to be the workhorse assessment of LV function in the Canadian experience, I would look towards perhaps doing that single assessment at index presentation and an uncomplicated inferior STEMI, perhaps not repeating any assessment of LV function unless the patient has a change in their symptomatology. If all of a sudden they're having new onset dyspnea, then of course, you know, you do the physical exam, ask about their symptoms, and then reassess the LV function indeed.
There's another question that many clinicians do pre-discharge EF, even if it's greater than 50%, because it may lead to avoidance of beta blocker or ACE therapy. So what do you think about that?
If even if, for example, you have normal LV systolic function on an LVgram, you get that more granular assessment with the transthoracic echo to document that it's greater than 50 and spare the need for beta blocker and ACE. It sounds like an expensive approach, to be honest. An echo costs about $275, and we have 66% of ACS patients with normal LV systolic function. So I would have to better understand what the kind of cost benefit would be there. But I'm wholly cognizant that beta blockers can be a bit of an annoyance for ACS patients. They have all sorts of undesirable side effects. I suspect that many of the patients will already be on an ACE inhibitor because of their comorbid disease. Up to 70% of patients have hypertension, of ACS patients, that is, and I think we showed that earlier. But I would be interested to see if there would be another way that we could avoid the beta blocker and ACE instead of doing a $200 to $300 test.
Okay, there's another comment here that 1.5% went from normal to severe LV dysfunction. And
Yes.
this could be maybe imaging misinterpretation. But if this was true using your algorithm, these wouldn't be picked on follow-up.
Absolutely. And this is a good point. And I think, you know, on the one hand, it depends, are you a glass 98% full sort of person or 1.5% empty? But I think it is concerning, and this did come up at another venue where this was presented, that these patients may slip down the cracks and they could be introduced to mortality-enhancing therapies and device-based therapies. And there was an initiative that I did not talk about in this presentation, the AMICA national initiative, which was led by Derek Chu and colleagues. And their whole focus was actually, while we were trying to decrease the number of unnecessary studies in normal patients, they were trying to increase the the frequency of important studies in those who need it the most, or the highest risk patients. And so their approach was any ACS patient who had an LVEF less than 45% on index presentation should have a reassessment of LV function, and the ultimate goal was to try to catch that 1.1% at the end of the day. And so I think where we're trying to move here is a shift. We're not trying to, tell physicians what to do, number one, and we're not trying to stop evaluations. I think what we're trying to do is just shift costly investigations from those who are least likely to benefit towards those who are most likely to benefit. And somehow we need to predict who is going to go on to be that 1.1%. We don't have the data to indicate that at present, but I think this would be very important information to know.
Good. So someone is asking if you can comment on the characteristics of the patients that bump from class 3 to class 1 in follow-up.
Yes, I can. So let's see if we kind of had our definitions of class 3. So I think that a couple of things come to mind. I think that, there's a lot that can be said with respect to revascularization and good medical therapy, cardiac rehabilitation, aggressive secondary prevention, and lifestyle modification. I think you could have some patients that might be around 34%, 33%, so right at the cusp of group 3, and therefore they could improve to group 1 instead of somebody who was at 9 or 11%. And there's also the phenomenon of left ventricular stunning, which may be playing a role, particularly in your STEMI patient population, where the LV was really down at index presentation, but after some time you have a fair amount of recovery, which may have been a contributing factor in some of those 25% who started in group 3 and finished in group 1 at first clinical follow-up.
So what do you think of, there's some data coming out from Mayo Clinic and other places that just do AI of the 12-lead ECG, and they can actually predict if the LV function is less than 35%. Would that be a better way of doing this?
Yeah, that's, I think using a test that probably costs $3 or $5 instead of one that costs much more than that. And if the ROC characteristics are very favorable, then, this is the direction, Carlos, that things are going, are algorithmic based approaches. There's some literature to suggest that, simple algorithms can outperform some clinicians. And as somebody who's been studying probably for 12 or 15 years and still doesn't have a job, I find this somewhat humbling that a 12-lead electrocardiogram might do better than me. But your point is well taken, and I think AI has enormous promise in the future moving forward.
So there's another last question I would say. It's what suggestions do you have to help influence behavior change? We know that physicians listening to a talk does not change either prescription or ordering test behavior. So what do you suggest?
That's a tough one. I think that we may have had a slide somewhere kind of here, kind of taking a QI approach and using a data supported approach to introduce a so-called small test of change, where we introduce a change at the institutional level. We prospectively collect the data, and if we can further support our hypothesis that these patients are doing just fine in clinical follow-up, then I think that this may persuade a proportion of the non-believers. I think it's important to have engagement from leadership and other major stakeholders to kind of perhaps utilize a top-down approach. But there's obviously going to be some inertia that would need to be overcome, and it wouldn't happen overnight. This would be more of a longer-term game plan.
And I guess the last thing is that I'm not sure I understand this. ICD when EF is 30 to 35% is of dubious value. Any idea of what your data would look like if a cutoff of 30% was used?
If you mean with respect to kind of where patients end up at clinical follow-up, if we just changed our cutoff? Go back to this slide here. I'm not sure I totally understand the question, Carlos.
Yeah, me neither. It's on the chat box there if you want to look at it. But
okay, I can take a stab at it. If we dropped our cutoff to less than 30, I think that we'd have now a bigger pool in our group 2 as shown here. And within that group 2, it would now be going from 35 to 50% and instead be going to 30 to 50%. And I think within that group 2, it'd be quite a mixed bag of a patient population. And I think it would be a fairly more of a heterogeneous patient population if we changed our cutoff, is probably what I would say to that. But you're right, there are a number of other factors that we didn't have a chance to talk about. The 35%, does it have to be exactly 35%? If I have a patient in follow-up who's under my care and their EF is 36%, would I send them for evaluation if they were still symptomatic for, say, something like CRT? I probably would. So there's some plus or minus bars associated with some of those numbers too.
okay, well, I don't see any more questions. Anyone wants to make any questions further?
I was wondering if you looked at the coronary anatomy of the patients that went from group 3 to group 1. Can you comment any changes or any coronary anatomy that would predict that improvement to group 1?
That's a good question. And we didn't specifically look at the coronary anatomy. The group 3 is a small enough group that this could, in principle be done as a spin-off assessment. We could sit down and have a look at the coronary anatomy and see if there were some features that distinguished these individuals from the ones who did not improve 2 categories or the ones who remained in group 3. I think it's feasible, but I don't have the data to precisely answer that question, unfortunately.
Okay, well, thanks, Danny. I think we'll leave it there. That was great. And we'll catch up later.
Sounds great. Thank you, everyone, for your attention. Take care.
Bye now.